affected, particularly the mucus glands which undergo hyperplasia. There is fibrosis of the bronchioles and parenchymal destruction. Basically, in asthma, there's contraction, exaggerated bronchoconstriction that occurs due to contraction of airway smooth muscle as a result of multiple inflammatory and bronchoconstrictor mediators that are released. In COPD, there are structural changes of small airways with closure of small airways as a result of disrupted alveolar attachments, resulting in air trapping and dyspnea. The clinical cause: asthma presents with exacerbations as an acute attack, which are usually precipitated by certain allergens or triggers. COPD, you have frequent exacerbations also, but they are more precipitated by infectious causes. And the number of exacerbations in COPD, unlike asthma, they also predict mortality risk. We know that asthma has good response to beta agonists, good response to steroids, moderate response to anticholinergic. COPD, on the other hand, has good response to anticholinergics as well as beta agonists, but poor response to steroids. So, what are the interactions between asthma and COPD? First is genetic susceptibility, and there are many genes that are common to both diseases, and I'll come to that later. Environmental factors, which I discussed: allergy, infection, smoking, air pollution. All this will cause bronchial hyperresponsiveness and airway inflammation, which can manifest as asthma early in life and COPD later. So, there is this concept of one airway, one disease continuum. If a child has frequent allergic rhinitis which is not treated, child develops asthma at the age of 10 to 20 or so as a teenager. If this asthma continues, okay, if we are not able to control the allergy much, then in later life, even in the absence of smoking, at the age of 50 or 60, patient will behave like a long-standing COPD. And we understand that most of the chronic severe asthmatics, they behave like COPDs. So to discuss asthma COPD overlap, I'm going to present two short cases. So first case is 49-year-old male presenting with acute worsening of breathlessness over the last 48 hours. Background of dyspnea, which is there since last 3 years, increasing in intensity and has made it difficult for him to perform his day-to-day activities. Patient has a childhood diagnosis of asthma. He is compliant and taking his inhaler, which consists of formoterol, that is a long-acting beta agonist, and budesonide, that is an inhaled corticosteroid. This technique is verified. Patient is a non-smoker. Patient also revealed seasonal variation in breathing difficulty on exposure to dust, which was more during winters. The patient is conscious, cooperative, and well oriented, afebrile, pulse is 84, 84 beats per minute, blood pressure is 130 by 94 millimeters of mercury, systolic by diastolic, respiratory rate is 30 cycles per minute, oxygen saturation is 92% on room air. There is digital clubbing, grade 3, and chest examination revealed bilateral wheezing with decreased breath sounds over infrascapular areas. So, what do we do in such patients? First and foremost, investigation will be to take a chest X-ray. So, this is the chest X-ray. So, you have in this chest X-ray, you can see some degree of hyperinflation of the lung fields, a flat diaphragm, particularly on the left side, some minimal blunting of the right costophrenic angle, and some bronchiectasis which is there. Now, this is a 49-year-old patient. Asthma is there since childhood. So, some degree of bronchiectasis may be there. So, we evaluate further. What do? We do blood counts, we do an arterial blood gas. Of course, 49-year-old male patient coming with breathlessness and ECG, and basic blood tests such as your sugars, creatinine, and liver function tests. So the CBC shows leukocytosis, elevated absolute eosinophil count 456 per ml. ABG is pH is 7.39, the PCO2 is 40, PO2 is 74, and the bicarb is 22. So ABG is otherwise okay except for some mild hypoxemia. ECG is normal. Random blood sugars 108 mg per dl. HbA1c, blood sugars, fasting, and postprandial are all normal. Serum creatinine is normal, and so is the liver function test. So we go back to the patient's spirometries that were performed 3 months ago. We find that FEV1 was 75%, FVC 88%. The FEV1 FVC ratio is 61%, which is less than 70%, so shows persistent effluent limitation. And the bronchodilator reversibility is also present of 15%. And diffusion capacity DLCO is 75%, which is acceptable. Further evaluation, what is to be done? Patient had leukocytosis, came in acute exacerbation, so we do a basic infection workup. Blood and sputum cultures are negative. Sputum CB nat is negative. We also evaluate the patient for allergy because he gave history of allergic symptoms. So the total serum Ig is 960 units per ml, which is elevated. Aspergillus specific Ig is negative. Now, why we are looking for Aspergillus specific Ig is because of allergic bronchopulmonary aspergillosis. It is one of the diagnostic criteria. Skin prick test done in this patient previously was negative for aeroallergens. So what then? Then we do a CT thorax which shows bronchiectasis, which is also seen on the X-ray, and upper lobe emphysema. Now, why the CT was important is to get some evidence of asthma COPD overlap, mainly the emphysema in the upper lobes. So, provisional diagnosis of asthma COPD overlap in acute exacerbation was made based on a compatible clinical picture, the presence of peripheral eosinophilia, elevated total serum Ig, and reversible airflow limitation. Treatment is initiated with oxygen at 2 liters per minute, nebulization with levosalbutamol, ipratropium, and budesonide, which is our conventional treatment for an acute exacerbation of any airway disease, empirical broad spectrum antibiotics, and IV hydrocortisone in tapering dose. The patient improved inhalational therapy, which was previously long acting beta agonist and inhaled corticosteroid, is stepped up to long acting beta agonist, long acting muscarinic, and inhaled corticosteroids. So, we have given this patient, in addition to formoterol and budesonide, which he was taking earlier, we have given glycopyrronium as well. Polyvalent pneumococcal and seasonal influenza vaccination is advised, and on subsequent follow-up visits over 2 years, the patient shows improvement of symptoms and reduced frequency of exacerbations. Second case, 63-year-old male, an ex-smoker with 37 pack years of smoking, but has stopped smoking now. Patient has an established diagnosis of COPD since 9 years based on spirometry and other tests. This patient presents to the emergency department at night with complaints of severe paroxysmal breathlessness, wheezing, and lower limb swelling since 3 days. Patient gives a history of being previously treated for pulmonary tuberculosis 22 years ago and previously diagnosed with seasonal allergic rhinitis with house dust mite allergy on skin prick test. Patient has history of 2 exacerbations over the previous year, otherwise his breathlessness was satisfactorily controlled on regular therapy with LABA/LAMA, that is formoterol and glycopyrronium, and occasional short course of oral corticosteroids. On examination, this patient is conscious, cooperative, and well oriented, afebrile, pulse is 90 beats per minute, blood pressure 120 by 88 millimeters of mercury, systolic by diastolic, respiratory rate is 28 cycles per minute, saturation is 86% on room air, clubbing of the digits is present, elevated JVP, facial puffiness, anasarca, and pitting edema over both lower limbs. Now, what does this history and examination tell you? That probably there is some cardiac component. So, that is one of the clues. And keep in mind why I'm stressing the cardiac component is because cardiac comorbidities are more common in COPD patients. So, chest examination reveals a barrel chest, bilateral wheezing, bibasilar crackles, right ventricular heave, loud second art sound with S3 ventricular gallop. Again, giving you a clue that there is some cardiac component. So we take a chest X-ray. We find that the cardiac size appears to be normal, almost normal in the chest X-ray. We get the findings of hyperinflated lung fields, prominent central pulmonary arterial markings, peripheral oligemia, vascular capillization, bilateral bronchiectasis with scarring, which can be explained to the which can be attributed to the pulmonary tuberculosis that happened 22 years ago, low flat diaphragms, and bilateral costophrenic angle blunting. Now, what gives a clue here is the upper zones of this X-ray. You can see the upper zones are hyperinflated. So probably there may be some emphysema. Another differential diagnosis to be considered in this patient is pulmonary embolism. So we evaluate this patient. What tests do? We do a CBC which shows us polycythemia, Total count appears to be normal. ECG gives us P pulmonal with right axis deviation, again perhaps going in favor of cardiac or pulmonary embolism. Arterial blood gas pH is 7.34, PCO2 is 56, PO2 is 51, and the bicarbonate is 26. So mild respiratory acidosis. Sugars, renal function, and liver function tests are normal. Recent spirometry is done at his last visit. So the FE1 is 59%, FPC is 77%, and the ratio is 55%. Bronchodilator reversibility is present in this patient. It is not present in a case of COPD. Alright, though the FE1 FEC meets the criteria for COPD of less than zero point 0.7 or 70%, bronchodilator reversibility is 19% in this patient. Body plethysmography shows normal total lung capacity with a high residual volume, and diffusion capacity DLCO is impaired, that is 55%. What is the other test you will do? You're suspecting pulmonary embolism, you're suspecting some cardiac component. So we go for a two-dimensional echocardiography. And what does it show? Dilated right atrium and right ventricle with a normal left side heart, normal ejection fraction, moderate degree of tricuspid regurgitation, and pulmonary hypertension with right ventricular systolic pressure, that is 55 millimeters of mercury. We also screen both the lower limbs by a Doppler ultrasound for DVT. Again, the lower limb Doppler ultrasound is normal. Infection workup is done. Blood and sputum culture is negative. Tuberculin skin test, sputum CB-NAT again negative. There is peripheral blood eosinophilia. The absolute eosinophil count is 620, and there is evidence of atopy because total serum Ig is elevated 1 to 57, whereas aspergillus specific serum Ig is negative. So we make a provisional diagnosis of acute exacerbation of asthma COPD overlap with pulmonary hypertension and right heart failure. Treatment is initiated with non-invasive ventilation at bilevel positive airway pressure mode because this is the treatment of choice of patients for acute exacerbations of COPD in with presenting with mild respiratory acidosis. Oxygen is given at a controlled flow rate of not more than 2 liters per minute. Again, nebulization with short-acting beta agonist, muscarinic agents, and budesonide is initiated. Diuretic therapy, a cardiac consultation is taken, and empiric broad spectrum antibiotics to prevent bacterial infection. Clinical improvement followed thereafter, and a CT chest was done. Now, CT chest gives us features suggestive of emphysema, which we are expecting, and CT chest also shows enlarged meal pulmonary artery with a diameter 3.6 centimeters. So it also gives us pulmonary hypertension. Patient improves and is discharged with advice for rest. Again, the inhalational therapy is stepped up from LABA-LAMA. Now we are adding ICS. So that is the difference between the first case and this one in terms of treatment. Okay, though the ultimate treatment given is the same, triple therapy. Triple therapy means two bronchodilators, dual bronchodilation action. You have beta agonists, you have anticholinergic, and you have for anti-inflammatory the inhaled corticosteroid. So it is called single inhaler triple therapy or SITT. Long-term oxygen therapy as the resting PO2 was 55 millimeters of mercury, which is one of the criteria for long-term oxygen therapy. Low salt diet, polyvalent pneumococcal and seasonal influenza vaccination, and pulmonary rehabilitation. Subsequent follow-up course, patient is compliant with inhaler therapy, compliant also with long-term oxygen therapy. No wheezing or nocturnal symptoms are present, clinically stable and otherwise exacerbation free. So, asthma, COPD, and cardiovascular disease. Cigarette smoking is a common risk factor to all the three. Both systemic inflammation and endothelial dysfunction are key pathogenic mechanisms for atherosclerosis. And apart from that, several processes are thought to interact with each other: oxidative stress, systemic inflammation, hypoxemia and hypercapnia, lung hyperinflation, pulmonary hypertension, and exacerbations. So, friends, when should we suspect asthma COPD overlap? The clinician's suspicion for ACO or asthma COPD overlap should be high in individuals aged 40 years and above or older with fixed airway obstruction on pulmonary function testing and bronchodilator reversibility is being present, who also report a clinical history or symptoms that are consistent with asthma, such as wheezing, nocturnal symptoms, and improvement with inhaled corticosteroids. Patients with asthma COPD overlap typically report more wheezing and dyspnea, have more frequent exacerbations, and a poorer health related quality of life than patients with either asthma alone or COPD alone. What is the genetic basis for this overlap? So, we all know the classic genetic predisposition of COPD is alpha 1 antitrypsin deficiency, but this prevalence is less than 2% in the general population. Some novel genes that are found to be associated with asthma, ADAM33, CCL5, interleukin 17, they are also being found to be associated with COPD. So ultimately, it is an overlap. You have inflammation, stress, smoking, pollution, environmental factors, triggers. Okay, so what happens? This forms an overlap that has common features of both asthma and COPD. Like asthma, there's eosinophilic inflammatory pattern. Like asthma, there's increased reversibility. There's better response to inhaled corticosteroids also in such patients. So, what are the risks? Genetic patterns, maternal smoking, childhood disease, allergy, elevated Ig, eosinophilia, Th2 type inflammation, and allergic rhinitis. All this gives you an outcome of asthma. Genetic patterns, aging, smoking, biomass fuels, TB in our country, okay, occupational hazards, poor nutrition, bronchial hyperresponsiveness, emphysema, all these give you COPD. The influence of environment and aging will affect the severity and chronicity of disease. So what happens in ACOS, you get something like a hybrid disease. Okay, low lung function, yes. Episodic wheezing, yes. Nocturnal symptoms, bronchial hyperresponsiveness, eosinophilia, just like in asthma. GERD, but better response to inhaled corticosteroids, unlike COPD. Limited reversibility of airway obstruction, hyperinflation, coexisting cardiac conditions, dyspnea and infection, just like COPD. So you have allergy, elevated serum Ig, eosinophilia, bronchial hyperresponsiveness, and the presence of bronchodilator reversibility. You have smoke, pollution, neutrophils, airflow obstruction, diminished diffusion capacity, emphysema. All this is seen more in COPD. So ultimately, this combined syndrome or this combined overlap, more symptom burden, more exacerbations, and a fall in the FEV1. So asthma COPD overlap was proposed initially as a discrete clinical entity by itself. Genetics, environmental, and early life influences determining asthma, then the progression to COPD, and something in between, that is asthma COPD overlap. ACO as the coincidence of asthma and COPD, or as a continuum of airway disease, which can be asthma on one side and COPD on the other side. The prevalence of asthma COPD overlap shows wide variation in studies, not just in India but also abroad. Prevalence is 11 to 61% in asthma patients, 4 to 66% in COPD patients, and 1 to 11% in the general population. In 2015, the Global Initiative for Asthma, that is GINA, and the Global Initiative for Chronic Obstructive Lung Disease, that is GOLD, released a joint statement which was then called Asthma COPD Overlap Syndrome, or ACOS, as persistent airflow limitation with several features usually associated with asthma and several features that are usually associated with COPD, which we just discussed. So, why was the term syndrome dropped? We know what differentiates a disease and a syndrome. So, from ACOS, how did it become ACO? In 2017, the American Thoracic Society and the NHLBI, that is the National Heart, Lung and Blood Institute, they published a joint workshop report on ACO, and it was concluded that ACO doesn't represent a single disease entity, unlike asthma and COPD, and that is why the word syndrome was dropped. Why it is important to recognize and diagnose this ACO? These patients have higher risk of exacerbations that are more severe than compared with patients of asthma or COPD alone. How does the clinician approach the management of patients who have both features of asthma and COPD? The definition of ACO, the assessment and management differences. We shall see. So asthma COPD overlap is a descriptor for patients often seen in clinical practice who comprise a heterogeneous group, and it is not restricted to a single entity. The current definitions of asthma by the GINA is that asthma is a heterogeneous disease usually characterized by chronic airway inflammation, is defined by the history of respiratory symptoms such as wheeze, shortness of breath, chest tightness, and cough that vary over time and in intensity, together with variable expiratory airflow limitation. COPD is defined by Gold as a heterogeneous lung condition characterized by chronic respiratory symptoms, that is dyspnea, cough, sputum production, and or exacerbations due to abnormalities of the airways, which can be bronchitis or bronchiolitis, and or the alveoli, that is emphysema, that cause persistent and often progressive airflow obstruction. And asthma COPD overlap or asthma plus COPD, these are terms used to collectively describe patients who have persistent airflow limitation together with clinical features consistent with both asthma and COPD. So the proposed definition of ACO by the Canadian Thoracic Society, a joint statement in 2017, they proposed defining ACO as being characterized by post bronchodilator airflow limitation that is not fully reversible in symptomatic patients with risk factors for COPD and who have clinical features of both asthma and COPD. So both the two patients I discussed, they fall in this category. They also proposed assessment and diagnostic criteria of suspected ACO patients. To know what must be asked are risk factors for COPD, symptoms compatible with COPD such as sputum, cough, persistent dyspnea, exercise limitation, exacerbations, and history of allergy or atopy, asthma, either a history of asthma in childhood or a confirmed physician diagnosis of asthma. Pre and post bronchodilator spirometry must be done. And they proposed essential and supportive criteria. So three essential criteria that were proposed was a diagnosis of COPD, a history of asthma, and on spirometry, the presence of persistent bronchodilator fixed airflow limitation, that is FE1, FEC less than 70%. The following are supportive but not required. So they are supportive criteria. Documentation, either current or previous, of an acute bronchodilator reversibility improvement in the FEV1 of 12% or 200 ml from the baseline value, sputum eosinophilia more than 3%, and blood eosinophils, current or previously documented, more than 300 cells per microliter. Yeah. The Japanese Respiratory Society also proposed diagnostic criteria for ACO a year later. They suggested features of COPD, fundamental aspects being over 40 years of age, chronic airway obstruction, and having features of COPD at least one of the three, that is smoking history more than 10 pack years or equivalent exposure to air pollution. On HRCT chest, low attenuation area indicating emphysematous changes, and an attenuated diffusion capacity less than 80%, and at least two features of asthma, two of 1 to 3, or at least two of the positive features of 1 to 3 plus two positive features of 4. So variable in diurnal, daily or seasonal symptoms or respiratory symptoms, past history of asthma before the age of 40, and a fractional exhaled of nitric oxide more than 35 parts per billion. Amongst the four supportive criteria were comorbidity of perennial allergic rhinitis, reversibility of airway obstruction, blood eosinophils more than 5% or 300 cells per liter, and elevated total serum Ig, which both our patients had. So in 2023, what is the current status? It's more likely asthma if there's a prior diagnosis of asthma. The age of onset is less than 20. Variation in respiratory symptoms within short periods. Worsening of symptoms at night or early in the morning. Symptoms triggered by exposure to allergens, dust, exercise, or emotions. Family history of asthma, ectopia, or eczema. Documented airflow limitation, variability, normal lung function between symptoms, no worsening of symptoms over time, and may improve spontaneously or have immediate response to bronchodilators or inhaled corticosteroids over weeks, and apparently a normal chest radiograph. More likely of COPD if previous diagnosis of COPD, age of onset more than 40 years, persistent respiratory symptoms, daily symptoms and exertional dyspnea, chronic cough and sputum precede dyspnea or unrelated to triggers, some exposure to a risk factor such as smoking or biomass, documented persistent airflow limitation, abnormal lung function between symptoms, symptoms slowly worsening and progressive over time. Rapid acting bronchodilators provide limited relief, unlike in asthma, and severe hyperinflation on chest radiograph. If there are three or more items in these lists that are present for either asthma or COPD, it is likely that the patient has that disease. But a similar number of items for both asthma and COPD suggests the possibility of ACO. So, how do we manage such patients? We initiate for COPD patients who are diagnosed with ACO subsequently. We initiate maintenance therapy with ICS LABA and consider step-up treatment to high-dose ICS LABA, addition of a LAMA, which is what we did. And of course, we refer the patient to a respirologist. If it is highly likely to be asthma, then we treat as asthma. If it is highly likely to be COPD, we treat as COPD. If there are features suggestive of both asthma and COPD, the current trend is to treat as asthma because you step up the inhaled corticosteroids and you may consider adding an additional bronchodilator. So, what are these kind of patients? Symptoms intermittent or episodic, but have started about the age of 40 or above. History of smoking or other exposures, low birth weight, or in our country, a respiratory illness such as tuberculosis, any of the asthma features, or lung function showing persistent expiratory airflow limitation with or without bronchodilator reversibility. So, ICS containing treatment is essential. We don't give ICS alone, we give a LABA, or we can give a LABA and or a LAMA. Okay. Maintenance oral corticosteroids are to be used only as a last resort. Review the patient after 2-3 months and refer for expert advice if diagnostic uncertainty or inadequate response. Bronchodilators, long-acting beta agonists, and long-acting muscarinic agents, sorry, remain the mainstay and they should be combined with inhaled corticosteroids for greater efficacy, fewer side effects, and reduction in the exacerbations. So again, the comorbidities affect outcomes, particularly the cardiovascular part. We have mortality, reduced quality of life, health status, increased dyspnea and reduced exercise capacity, more hospitalization, and healthcare utilization and expenditures. So just to evaluate, are LABAs to be given in cardiac patients because many of our patients will be old. So both inhaled beta agonists and anticholinergics increase the heart rate and therefore it is thought they may increase the risk of ischemia. The overall beta agonists have a stronger effect on the cardiovascular system than anticholinergics. And beta antagonists, such as beta blockers, are considered important cardioprotective agents because of the anti-ischemic effects. Beta 2 receptors are also present on numerous inflammatory cells, which could contribute to their potential for inducing adverse effects. The adverse effects of beta adrenergic stimulation include increasing heart rate, which also increases the myocardial demand, and it may also cause direct myocardial injury or necrosis that could lead to ischemia. So, LABAs have been previously implicated in prolonging the QTC interval, decreasing potassium levels, and glucose concentration. A systematic review and meta-analysis of 12 studies with more than 1,600 participants of asthma found better efficacy with salmeterol, particularly in some outcomes such as number of days without an attack and the decrease in FEV1 after inhalation of methacholine. So methacholine is given in what we call bronchoprovocation testing, which is one of the gold standards for asthma diagnosis. They also found that administration of salmeterol might be beneficial for some patients as compared to formoterol. Also found that LABA combined with ICS did not increase the risk of acute myocardial infarction. In fact, low dose ICS reduced the myocardial infarction risk in patients with COPD. With the close association between both asthma and COPD, it is quite possible that treatment for one condition may influence the other. And therefore, you must treat all associated conditions. Investigate for and treat comorbidities, cardiovascular, GRD, OSA, obesity, psychological. Smoking, three arms of our important non-pharmacological management. Smoking, vaccination, and pulmonary rehabilitation. If the patient is a smoker, encourage smoking cessation. Enroll the patient in a smoking cessation program. Vaccination. Two of our cardinal vaccines, the polyvalent pneumococcal vaccine and the seasonal influenza vaccine given every year, pneumococcal vaccine every 5 years. These are known to reduce the risk of acute exacerbations, acute infective exacerbations, and pulmonary rehabilitation because it gives the patient better exercise tolerance and a quality of life. So the pharmacological management depends mainly on the patient's symptoms and lung function. We initiate with a inhaled corticosteroid in moderate or low dose. We may step up the dose of inhaled corticosteroid, see how the patient improves, and we may add a LAMA. So it all depends on the symptoms, exacerbations, and what is proposed now, a pragmatic treatment approach in the year 23. Just like we have A, B, C, D groups for COPD, we now have an A, B, C, D group for asthma COPD overlap as well. So group ACO-A, low to medium dose of ICS, you may add LABA and you may give triple therapy. ACO-B, low medium dose ICS or triple therapy. ACO-C, triple therapy is to be started upfront. And ACO-D, LABA, LAMA or triple therapy. Depending on several factors, the severity of symptoms, the reversibility on airflow obstruction, etc. In both our patients, we gave triple therapy. Coming to the end of my talk, it's good to diagnose ACO, but it's not enough to treat. You have to look at what additional benefits can you give the patient. So, like I told you, for smokers, smoking cessation, for persistent dyspnea, pulmonary rehabilitation, for respiratory failure or sleep disorders, non-invasive ventilation or long-term oxygen therapy, reduction, acute exacerbation, vaccination, which I discussed, biologicals, particularly if there's an asthmatic component, allergen immunotherapy, again, if there's an allergic component, immunomodulators such as anti-inflammatory agents such as macrolides, roflumilast, all these can be tried. One slide on biologicals. We have the well-researched anti-IG monoclonal antibody omalizumab, which has been extensively researched in asthma as well as COPD. Anti-interleukin 5 or anti-IL-5 receptor alpha therapies such as benvalizumab, mepolizumab, and veslizumab. Anti-IL-4 receptor alpha and IL-13, that is dupilumab, and the anti-thymic stromal lymphopoietin, that is tezepelumab. So out of all these, the best evidence for ACO is with omalizumab. It reduces exacerbations, improves symptoms moderately in allergic asthma patients with elevated serum Ig and sensitivity to perennial allergens, and it may be advantageous in certain patients of asthma COPD overlap. We must have a written action plan that promotes rational and stepwise use of drugs depending on disease severity and a factor in our country also, patient affordability. This written action plan will also discourage polypharmacy and over the counter medications. Written action plan should also include briefly what to do during an exacerbation, including what medications to take. So, to wind up my talk, dear colleagues and friends, asthma COPD overlap exists. Asthma COPD overlap can confuse the clinician sometimes. It's a diagnostic and therapeutic dilemma initially. It imposes a management burden and it also costs, okay, in terms of an economic burden. In patients with a primary diagnosis of COPD or asthma, timely identification of asthma COPD overlap has implications for better prognosis and treatment. Such patients experience frequent exacerbations, poor quality of life, rapid decline in lung function, and higher mortality than asthma or COPD alone. Patients who have asthma with a COPD component tend to present with severe hypoxia because of irreversible or fixed airway obstruction and impairment of the alveolar diffusion capacity by emphysematous changes. In contrast, patients with COPD who have an asthmatic component not only have exertional dyspnea but also develop paroxysmal wheeze or dyspnea at night or early in the morning. The criteria to diagnose asthma COPD overlap in COPD includes a positive bronchodilator response, sputum eosinophilia or previous diagnosis of asthma, elevated Ig or history of atopy. These features were found in our patients, both our patients. Asthmatic features such as eosinophilic airway inflammation are promising indicators for prediction of ICS response in COPD patients. ICS with LABA and or LAMA provides significant alleviation of symptoms in most of the patients of asthma COPD overlap. Some studies suggest that more severe patients may also respond to biologicals indicated for severe asthma. The greatest evidence is with omalizumab. The treating physician may adopt any of the modalities available to diagnose and assess asthma COPD overlap and revise treatment accordingly depending on availability and resources. Optimal therapy with bronchodilators and inhaled corticosteroids remain the mainstay of treatment for ACO with good efficacy and fewer adverse effects. We need to always look at cardiovascular safety in elderly patients and non-pharmacological interventions, which I discussed, smoking cessation, pulmonary rehabilitation, they all play a role. Dear colleagues, I am very grateful to all of you and respected chairpersons for giving me a very patient hearing. Thank you.
Thank you, Dr. Nikhil, for your nice presentation covering all the corners of the topic, very elaborative way, and also it is very lucid. And we have 5 questions. Can I raise the question? Dr. Nikhil, you please respond.
Yes, sir.
First of one is a patient of obstructive airway disease comes to OPD with slight increase in symptoms. Then how should we relieve his acute symptoms? By choice number 1, LABA ICS, SOS and maintenance, or number 2, by SABA for 3 to 4 days and then SOS when required.
So both options can be used, sir. So if we are suspecting, again, it will depend on which airway disease we are suspecting. If it is asthma, then we would definitely give the inhaled corticosteroids. Okay, but SABAs have to be given for relief of the acute symptoms. Nowadays, formoterol, which is a long-acting beta agonist, but also a fast-acting one, there's evidence to show that formoterol is equally effective, like salbutamol, levosalbutamol, and ipratropium, in relieving acute symptoms. So maybe 10, 15 years down the line, we will be even using LABA ACS as a standard of care.
Yeah. Thank you. And second question, is it better to use the term obstructive airway disease in diagnosis when PFT is not available?
We can make a clinician diagnosis of airway disease, sir. For to call it obstructive airway disease, ideally PFT or spirometry is essential. However, certain features that involve that or suggest airway obstruction. One can be the presence of wheeze and significant dyspnea with use of accessory muscles because the airways are compromised, or a silent chest. If any of these features are there, one may add obstructive to airway disease because there is some clinical evidence that there is some evidence of airway obstruction. However, obstruction should always be confirmed subsequently with a spirometry once the patient is more stable.
So spirometry is a must, and when we can't diagnose acutely clearly asthma, COPD, or ACO, we broadly write the term obstructive airway disease. And the third question is by Ronak Roy. What are the indications of low flow oxygen therapy in ACO patients?
So, as you see, was our second patient of ACO was also prescribed long-term oxygen therapy. So, low flow oxygen therapy for patients of ACO who are predominantly COPD, yes, it has a role. It has an initial role, which is in the patient comes in the emergency, okay, and there is some hypoxemia or desaturation. The first thing to do is to supplement with oxygen. In COPD patients, we try not to give oxygen more than 2 liters per minute
Yeah.
for two major reasons. One is we don't want to suppress the hypoxic respiratory drive on which the patient is critically dependent to breathe. And we know that oxygen is a pulmonary vasodilator. So, in patients of COPD with diseased lungs and airways, what we will be doing is increasing blood flow not only to well ventilated but also poorly ventilated parts of the lungs. That will cause some ventilation perfusion mismatch. So, when we give In COPD particularly, we always give controlled oxygen therapy. However, the indications for oxygen for long-term oxygen therapy at home or domiciliary oxygen therapy in patients of ACO will be same to those with COPD, that is uh, persistent hypoxemia, with a resting PO2 less than 55 millimeters of mercury, or 56 to 59 with some evidence of right heart failure or pulmonary arterial hypertension. So this was there in our patient also.
And Roundock has another question. What is the best LABA Lama ICS combination for ACO?
So the base LABA LAMA combination nowadays is fortunately available in one inhaler. It is called SITT or single inhaler triple therapy, and it consists of formoterol 12 micrograms, glycopyrronium 25 micrograms, and budesonide 400 micrograms. So this is the base combination which I would say we can try in all our patients suspected or diagnosed with ACO. It is to be given twice a day.
And one final question is role of oscillometry in ACO is any? Please elaborate.
Yes. So basically, airway oscillometry, it is thought it is a new concept, but it's not actually a new concept. It evolved, based on the concept of airway ecography, and from there, oscillometry evolved. It can be found in many of our classical textbooks of medicine also. So what is done in oscillometry is there is a loudspeaker, okay, and there is a reception. You generate sound. The sound is converted into waves which pass, and the reflectance, reactance, and impedance is measured. So based on that, rather than, and the patient doesn't have to forcefully expire such a in spirometry. The post expiratory maneuver is not required, and therefore it is more comfortable for the patient. In children also, because it is a non-invasive assessment of airway function. Yes, airway oscillometry has a role in asthma and in COPD. This is well established. In ACO, now upcoming literature is there to show that if the reactance and impedance are affected early in asthmatics, then you are more likely to go towards a diagnosis of ACO.
Yeah, and one question in the chat box that came in: what is your opinion regarding potassium supplementation in Indian perspective? I think question is in the context of increasing lava use or
Yeah.
maybe like that.
So it is known that LAMA and LAVA both affect the potassium levels. Whether inhaled drugs will affect so much, but yes, it has been found that in elderly patients, who are on LABAs and LAMAs or both for a long time, the potassium levels can be altered. Whether this is correctable by potassium supplementation, there is not much evidence
Not.
to give a recommendation in favor or against as of now.
And do you think that there should be a practical training of undergraduate students regarding the collect inhaler technique, and should it be introduced in the UG curriculum?
Yes, it should be introduced in the UG curriculum because in many countries, particularly in the UK, the National Health Services, they are training general practitioners now on inhaler technique, nebulizer use, etc. So these things nowadays, inhaler and all these things, they are what is considered a primary level of care for which our MBBS doctors are supposed to be trained. So definitely the correct inhaler technique should be trained, and it should be taught to all undergraduate students at some point in the medical curriculum.
I completely agree with you. These are the questions. Now, I just want to wind up with my comments, a few comments that in SEO, we must take the history properly. And in every follow-up, we have to look for any change in symptom. And spirometry is a must in these cases. And we usually do chest X-ray in all cases, but in selective cases, we have to go for HRT-specific products to look for any emphysematous obvious changes and also any bronchiectasis and other comorbid findings. And in the investigation purpose, in every exacerbation of symptoms, there must be ABG test. thing, which can raise whether PCO2 raised or not. So in which way we will manage or not, which will be the direction of oxygen therapy, and also uh, some ancillary tests like excluding presence of ABPA or any other comorbid conditions. We have to do the investigation. In the management aspect, it is very important to decide where we give low dose inhaled corticosteroid or where we increase the dose or we avoid the inhaled corticosteroid, particularly in these cases because it is asthma predominant. There is a role of increased inhaled corticosteroids, and in predominantly COPD component, then we have to keep low dose inhaled corticosteroids. And immunization also we have to plan accordingly based upon the diagnosis. And GINA guidelines laid the diagnostic criteria and also the management approach, which Dr. Nikhil already explained in a very lucid way. So I think this webinar will be helpful for the participants who joined, and like to thank all the participants who joined and particularly interacted with their raising their questions, and all are very nicely answered by our presenter, Dr. Nikhil, today. Now, I finally like to thank API West Bengal chapter also to invite me as a chairperson in this program. Now, I hand over this webinar to Dr. R.N. Sarkar and Dr. P.S. Karmakar, who are present, what I am seeing. Thank you, sir.
Thank you. Thank you all, Nikhil, for your excellent presentation, and also Aparup for nicely compiling the concluding remarks. Now, I will request Professor Pathak, you are there?
No, Dr. Tapos Bandyopadhyay will offer vote of thanks.
Yes,
Okay.
yes, I am there.
Over to Dr. Tapos.
Tapos,
Yes,
please.
thank you.
Conclude.
So, on behalf of West Bengal Forum of Indian College of Physicians, the academic wing of Associations of Physicians of India, West Bengal, I would like to thank Dr. Nikhil for this fascinating talk, who has cleared many confusion and many queries, and aptly described how to approach a patient with this overlap in a holistic manner. I would also like to thank today's chairpersons, come moderator, Dr. Aparup Dhua and Professor Supriya Sarkar for nicely conducting this session. Like to thank our chairman, ICP Forum, Dr. R.N. Sarkar, Professor R.N. Sarkar, Professor P.S. Karmakar, who is the honorary secretary of ICP West Bengal branch, and chairman of API West Bengal, Dr. Partha Sarkar, along with the course directors of this particular webinar. I'd also like to thank our office bearer, particularly Kaushik, and last but not least, the delegates, the participants, the postgraduate trainees who have joined today's program. And definitely, it's a pleasure to have this type of program, which is very much useful. And I think those who have not joined, they have missed a very important topic to clear their confusion. Maybe this will be later on uploaded in the YouTube channel, but definitely live webinar is more useful at any point of time. I thank our microlab laboratories, pharmaceutical companies who is sponsoring this masterclass for a long time. With this, I hand over to Dr. Professor R.N. Sarkar and the course coordinators of this program. Thank you so much.
Thank you, Tapos.
Welcome.
Our next webinar will be in April, maybe 6th or 13th. Partho, you are there?
6th. It will be on 6th of April.
6th. We'll have
6th
tropical medicine.
Yeah, notice will be given in due course of time.
Okay. So you conclude, and thank you all for joining.